I have the pleasure of introducing our next speaker, who's our plenary lecturer for today, and it's Dr. Kyle Gunnerson, who is a physician, and he's an ED and internal medicine and critical care physician from the University of Michigan. I actually invited him because we both grew up in Kansas, but aside from that, he actually has tremendous expertise, and what he's going to talk to us about is that connection between the ED and the ICU, and one thing that we often struggle with. But he's very uniquely suited, obviously based on his training, but he's really sort of built a program at the University of Michigan that pulls those two disciplines together and makes it work well. So we're all going to get a chance to learn a little bit of how they do that in Michigan and how we might think about it in our own hospitals. So Kyle, thank you for coming to Atlanta, and teach us what you can.
Great, thank you, Greg. All right, thanks everybody. Like Dr. Martin said, wear a couple different hats at the University of Michigan. Part of my time I'm up in the cardiovascular ICU, rounding up there, and I'm also working down in the plain emergency, the regular emergency department. And then there's also a new part of the IC of the ED that we developed called the EC3, or the Emergency Critical Care Center, which is an ICU, and I direct that, and I work down there the rest of my time. So have a perspective from both sides. As we go through kind of the journey, this is kind of, I'm going to take you through what we did over the last few years and why we did it, and at the end it'll be the fun stuff. We kind of get to show and tell our results. I want you to think of a couple questions, which will come up. Here are some of the questions, where you can think about, and these really are some of the basic questions, ironically, that we were going through, several years ago, back in 2012, when we were thinking about this concept. Disclosures, I have some funding, through a few federal agencies and some industry. Nothing that's going to impact this trial or this study or this conference at all. So the objectives as we go through this journey about our process, we're going to talk about the current perspectives of critical care in the ED, the University of Michigan's approach of how we actually, went about solving some of these problems arising from the ED and the ICU. How we did it, basically our process about this, and really, again, because we're an academic center, a lot like Emory, we have operations, then the clinical, tripartite mission of education, research, and the clinical operations part. And then at the end, we can talk about the year-to-date results, and we kind of wrapped up our comparison group at the late in the fall, and we'll have those results now. I can let you see about those. So University of Michigan is very similar to Emory as far as a large academic institution, very similar to a lot of academic institutions around. It's basically a 1,000-bed hospital, does a lot of research, et cetera, et cetera. This, again, it's very comparable to the Emory model here, other than, we don't have as many community or outside satellites. Now the ED as well is essentially a large academic emergency department. I want you to consider now, when we talk about the before and after, the before part, the part that got us thinking about what we need was roughly around 2012. So around 2012, this is what we were facing. We had a volume, very complex patients. Came in around 70 to 75,000 adult patients a year. The admission rate was fairly high. It's around 35. We're up to almost 38% now. The admission ICU rate was around 10%. We took about 300 to 400 transfer calls through the ED a month, and we actually had a decline about 25% of our ICU transfer calls. We declined about almost 1,000 patients a year just because we didn't have any space for them. We also had a left before evaluation rate of around 3%, which is about a little bit higher than the standard here. And then the kicker is that our projection, our volume increase was roughly around 3 to 4% growth each year for the ED, but our ICU projected growth increase was around 10%. So remember, now is 2012. At that time, why was that important? Well, if you look at the physical plan of U of M, they saw about 16% of all the admissions, all the entrance to the health system was through the clinic. And then another about 30% was through same-day surgery, whereas over 50% of all the people coming into the big operation taking care of patients came through the ED. So we really were the front door to the entry point into the ICU. So we really needed to be able to solve this problem, and we really owned it. Like, this is something the ED needs to take care of. Now, we were right smack dab in the middle, the same way as Emory and other large institutions, right smack in the middle of an alarming trend that's really kind of going over this country. And this has been really peaking up in the last really 2 decades, that we're seeing ICU admissions from the ED that are doubling. And this data is even old, it's even higher than that now, through the ED. The admission rate from the ED has gone from about 9.9% to almost 2%. A third of all these ICU admissions, they spend more than 6 hours in the ED. Now, if you look at the number of visits going through the ED, that's going up by around 10% a year, these patients that are going to the ICU. However, just going along with this, a third of the patients spend more than 6 hours, the amount of time that we're delivering critical care in hours in the ED is going up by almost 25% each year, okay? So that's a reflection of there's no place for these patients to go. The beds are full upstairs, and they're having to deliver critical care in an environment that never was really set up to do this. Why is that important? Well, as we all know, when you're faced with acute critical care illness, it's very time sensitive, anywhere from minutes, such as a cardiac arrest, to the golden hours, of trauma and sepsis. And in the first few hours of care, you can really make the biggest impact on our patients. You can, change these acute scoring systems the most. Your Apache score, MOD score, however you want to look at it. These scores are extremely influential in the first few hours of care. Now, you might ask the question, well, what happens if you just way down in the ED? That's no big deal, right? Because the ICU team comes down and take care of them. Well, there's been several studies looking at boarding ICU patients in the ED. And the longer you're staying in the ED, the increased risk of death you have in these patients. And it looks like that time point, that inflection point, somewhere around 3 to 4 hours. And anything after that, just increase your odds, of dying, compared to the patients who get upstairs quickly. Now, this isn't just medical ICU. This is medical ICU. These studies here look at all comers: medical, surgical, and even the subspecialty, the neuro ICU and the cardiovascular ICUs. So in 2012, going back to Michigan, where were we? All right, we've seen about almost 2,000 ICU admissions coming through the ED, which roughly came out to around 5 a day. We had crested that magic 4-hour window where actually the average length of stay was over 6 hours for our patients. The projected growth, again, remember, was about 10% growth of our ICU population, going forward. At that time, we only had 3 resuscitation bays. Last time it was renovated was back in July. We really didn't have the physical space or the resources to take care of these patients. The staffing for this, we had some staffing for a nursing standpoint within the resuscitation bays, but outside of that, we really didn't. And then once the patients, there's no thought about what we're going to do with these patients from an attending standpoint. You could have 20 other patients mixed right in with 3 very critically ill patients. So we really weren't able to take care of the patients we wanted to. Now, an important thing to think about is that a large number of our patients that we were providing critical care services for on ventilators, having Ventrixin, central lines, etc., they were actually cared for outside of a resuscitation base because we just didn't have the room. Almost 500 patients a year admitted to the ICUs didn't even see our resuscitation bay for that. And then also, again, we talked about we couldn't see these patients. We couldn't get patients transferred to our institution that needed to come there because we just didn't have a place to take care of them. So what did the administration do for this? They changed their strategic plan, right? They wanted to help us out. So wanted to help us out, they say we want to double our adult high complexity market share from 6% to 12%. Well, I never thought about what happens to the ED. That just means more critically ill patients. That that high complexity share patients. That's just another way of saying we want the really critically ill patients to come to you. Well, you're basically now just throwing fuel on the fire. We couldn't manage what we were seeing, and how are we going to increase, really double the demand for this? So we really were put in a system when our current structure, we weren't prepared to handle these challenges at all. So again, just to summarize where we were in 2012, we had increasing ED visits, we had an increasing ICU demand, coming in right off the street and also being transferred in from the ED, an increasing ED length of stay for these patients, and we really weren't following our outcomes. We really didn't know what was going on with these patients. Nobody was really tracking, it wasn't on their radar. So a lot of this is perspective, right? And you can probably empathize for our patients is when we see somebody as an ED doc, you see somebody comes in and they're sick, and we get the process started. And we call up the ICU fellow and they say, hey, we got this really sick patient who needs an ICU bed. The ICU fellow says, yep, I agree, absolutely, I'll get you a bed. And so what does the ED do? They say, great, all right, both. ICU team's taking care of this patient. What's the ICU team do? They're the other guy. They're saying, oh, okay, well, we don't have any beds. You won't have any beds for 8 hours, but at least the ER's taking care of them. So what happens is that the poor nurse is stuck at the bedside trying to, call both sides, and by that time the ED has signed the patient out to somebody who has no idea what's going on. The sign out is really sick patient, ICU's managing. Upstairs the ICU is, we've got 2 codes on the floor, the ED's taking care of this. And at the end of the day, the nurse is, circling the drain, trying to ride along with the patient, trying to figure out how where we're going with this. So we really need to take care of this. We needed to fix this. So how we went about this was, pretty systematic. We had to do an internal audit. Okay, we needed to look at a needs-based assessment, both at our own critical care operations and also as an emergency medicine, standpoint. We found out from our critical care, we delivered great critical care, but it's very siloed. There's really no crosstalk. Our neuroscience ICU never really talked to our cardiovascular, never really did to the medical, et cetera, et cetera. No crossover, really didn't have any help. And from the emergency standpoint, we didn't have the physical plant, the staffing, or even the knowledge to manage these patients. However, the bright side was there was an emerging specialty. In 2012, we were able to have a pathway now to where emergency medicine residents can go in and do critical care training and then get board certified. And so there's an increasing pool of EM trained intensivists that we could potentially tap into. As of today, we have about 180 that have gone the medicine pathway, and about another 70 or 80 that's gone the anesthesia, and about 20 have gone the surgical pathway. So we have a growing group of docs that are bringing some content knowledge that's unique to this, and we wanted to tap into that. So what we're really talking about is this paradigm shift of where we have these all isolated silos. As far as critical care is concerned, we wanted to be able to tie these silos together, have them talk to each other, have us cross-trained where we can manage these patients, at least in the first 12 to 24 hours safely within the confines of our ED. And we needed to do this in a way to where we build bridges where bridges really hadn't been built before. Now going forward, we had to have a North Star to help kind of guide us from the 30,000 point view. And essentially about this, we wanted to create this infrastructure to where we can provide these time-sensitive diagnosis and treatment while we take care of these injured patients within the ED before they end up in their destination phase. And as long as we could tie in whatever decision we're making to this North Star, this kept us in line. One of the ways that we went about this is buying a lean principles to this, is where essentially it's a plan, do, check, and act. It's, you come up with ideas, and this is a very systematic way of doing this. I'm not sure if you're familiar with the lean approach, but by doing this, we needed to create a multidisciplinary team for this approach. Now, this was unique in the University of Michigan. We had physicians, we had pharmacists, we had respiratory therapists, we had nurse practitioners, we had PAs. We had nurses that brought this team together, and this was, just a small composite of this team right here. Essentially, anybody who was going to see a patient, have stakeholders in the patient, while they're in the ED or even downstream, was represented on this team. And that was just the ED. We also built teams from the inpatient arena as well. Now, we met, many times, 2 years prior to this. This took actually a lot of planning for this. We even went out and saw other systems. New ICUs that were built, renovations of primarily ICUs. We did tour a few of the other EDs more for the resuscitation phase. Meanwhile, along the same time we were getting ideas from a physical plant standpoint, we really wanted to work on staffing and other operations standpoint, education model. How are we going to incorporate our residency? All right, there's a lot of people who might be affected by this, various residents and fellows. Research, big research endeavor at U of M, a lot like Emory here. We needed to make sure this would be leveraged in the right direction. And then at the end of the day, it all boils down to how do we take care of our patients. We needed to come up with, guidelines how to manage these patients, and then how to incorporate, everybody's favorite, the IT part of it too. So we had to end up building all this wonderful stuff into, Epic. So this is what we came up with, and this is very similar to what we do now from a staffing standpoint. Now, when we go about this, you'll see that the timeline goes across the top of the bar. This is a whole 124-hour period. So on the top, we have 2 attendings broken up into that 24-hour period, 12-hour shifts. And at the bottom, you'll see respiratory therapy and pharmacy has a presence within the ED and our ICU area down there for the whole 24 hours. This really wasn't much change. We just kind of, at least for the respiratory therapy, we changed their location to where they're primarily located in our ICU. We also broke this down for the non-physician providers into a group of 3. We either had a PA, a fellow, or a resident. And we had 2 of those made up the team, during the time that we take care of these patients. And then one of the biggest things about this that makes this work is our nurse staffing. Is that we staff this the same as we'd staff an ICU bed, where just the baseline staffing for this model is a 2-to-1 nurse staffing ratio, to where you have 1 nurse that manages no more than 2 patients, and when they need to, we can flex up and manage 1-to-1, and in the rare cases, we can even do 2 nurses to 1 patient, like when we manage an ECMO patient. Now it actually could be ramped up to 3 patients. So this was, we were working on this, this model from a staffing standpoint, and this really has not changed much since we came up with that over, 5 years ago. Now, how do we train this? How do we get people competent for this? So from the attending side, we had, at the time we actually opened the doors, we had 4 EM intensivists. We're up to 6, and we're going to have 7 this summer. So we have 7 content experts of EM intensivists. So those that are not fellowship trained or intensivists, we have put on an FCCS, or Fundamentals of Critical Care Support based didactic program that we put on every 6 months. And we run our attendings through this, and we run our PAs through this, and we run our nurses through this. And as far as an attending standpoint, we need to keep this certification active every 2 years. And we also go through other things that make the feeling of ownership, on the shoulders of the attendings who rotate over there. So we have a division of critical care now, and the attendings that rotate over there have to, participate in our divisional meetings. We have various educational meetings. We have research meetings. We have a specific ED critical care journal club that our fellows put on. We have monthly CME lectures that our intensivists put on, not only just for the nurses or the respiratory therapists, but for the whole group. So there's many opportunities to stay up to date on acute critical care issues right within the emergency department. Now, from the nursing standpoint, we were very fortunate to have a very passionate trauma nurse who also had EM training, who came back down from the trauma ICU to help us lead this effort. Renee Havey, she really followed in essentials of critical care orientation from the AACN and really patterned us after that. So to start off with, initially we had all of our nurses go through an 8-week course upstairs. So it roughly broke down to 4 weeks in a medical ICU and then 4 weeks in some type of surgical ICU, so they could get an idea of the patients and the protocols and what we're dealing upstairs. Again, we went to a PDCA cycle as well as seeing how the training is working and how much that's happened. Now that we have a really good core group of nurses who've been working in our ICU now for almost over 3 years, we've come to a sweet spot to where they still go upstairs for about 4 weeks in our medical ICU, but then the other 4 weeks are down in EC3 as our ICU area to get the training hands-on. Now, from our education standpoint, this is a pretty big endeavor. We have a dedicated critical care curriculum. Now, this is focused at residents. This is focused at med students. We have fourth-year med students actually do a sub-I. They come, and half of the months they're from internally, and the other half actually they do an external rotation. We have our residents have now incorporated this into their residency. It used to be a rotation. Now it's a mandatory, it's a revolving every few, they work every few shifts every month rather than just a dedicated time over there for a rotation. And it's grown, the word's gotten on the street. So we now have internal medicine residents. OB/GYN residents actually weren't getting enough of what they wanted to see in the surgical ICU, so now they're coming and they're rotating with us as well. And we're getting a lot of interest from residents outside of the institution. From a fellowship standpoint, we actually created 2 pathways for emergency medicine training docs. So we have an anesthesia pathway and we have a medicine pathway. But aside from those, it's a mandatory rotation for our anesthesia intensivists because they don't see this at all in their training. As you can imagine, anesthesiologists, especially the anesthesia intensivists, usually see patients after they come out of the OR. They rarely see patients de novo sick right off the street. So this is a mandatory rotation for them. Same way with our neurointensivist training. And then we have electives that are available for the pulmonary side and the surgical side as well. This is one example of where we have one of our med students giving her a final presentation. We have it in our curriculum. We try and do it right there within our resuscitation phase if we're able to in the morning. So as I mentioned earlier, we do have 2 fellowships. We graduated our first class in 2016. We put about 2 each year through, so we have 4 fellows total. They becoming more and more involved within the workings of our emergency critical care center. The nice thing about our program with this is that it's the first one in the country that actually dedicates time to seeing patients in an environment like ours. The rest of the training is the same across all the other fellowship programs in the country, very similar to what you do here. But the one thing that's unique is the EM trained intensivists spend 6 months during their 2 years down to see the workings from an operations standpoint, from an education standpoint, from a research standpoint in an EC3. Hopefully the idea is, if they're not going to stay with us, they're going to be able to go out and replicate this or something close to this, at other institutions that need it. From a research standpoint, it makes sense when you think about it. You build the competency up of taking care of these patients when they're really sick to where you can provide good critical care, and then you're in an environment at 24/7. You now can use that as an enrollment hub for all critically ill patients. Before, we were limited to when a patient actually would have to go to an ICU environment to where we would approach them, just because the nurses didn't have the skill set or didn't have the time or the resources to maybe carry out a protocol. Where I've been able now to expand our pool of screening and enrolling for critical care studies actually within our EC3. With that, we have 3 NIH-funded trials that are ongoing at the time. We work very closely with a large multi-disciplinary research group called MCIRC. Again, our goal is to have a 24/7 enrollment in all of our critical care trials. This is just one example. Kevin Ward worked with me when I was back at VCU, and we both came together here at University of Michigan. But just as we wanted to create a nice paradigm of breaking down silos within the care environment, Dr. Ward's been actually working the same way within the School of Engineering, School of Chemistry, School of Bioengineering, etc., breaking down these traditional walls within the college, within the University of Michigan, to where now we're tying these groups together in the hope of taking care of our sickest patients. Now, moving on towards taking care of our patients, the most important part of this, the clinical care part of this. We put together a critical care advisory group. The critical care advisory group was representative of all of the ICUs in the hospital, neuro ICU, medical ICU, etc. Not only was it the physician leader, the unit director, but also the nurse leader, pharmacy, as well as respiratory therapy. They all came together, all part of the advisory group. We met every month, and we thought we'd start with some low-hanging fruit. What are the most common diagnoses admitted to your unit? And we picked those from each unit, and we put together, and we came up with protocols and came up with care sheets with this. This was our first 6. Again, these are non-controversial. Nobody really had a lot of controversy about how to manage these patients. We just wanted to front load a lot of that care that you get upstairs down within the ED, and actually to formalize that as far as our concern was in care sets, so we could easily click this off and have a way to track this. From an operational standpoint, how do we make this work? This kind of was the most tricky part. Ben Basson is an operational genius, and he's not an intensivist, but he is by experience now, but this from on-the-job training, it seems like. It's really good. We needed to figure out how we can get patients over there. Well, working on the definition of who belongs over in this resource-rich environment. Obviously, if the patient's requiring critical care services, they're intubated or they got lines in, they need pressors, those are the slam dunks. But we also wanted to make it flexible to where if it's a very nursing resource intense patient, where that nurse is in that room every 5 minutes, that's something that's taking that nurse away from their other patients within the ED. And those would be the cases we'd actually bring that patient over to our EC3 if we had room and we could actually manage those patients. May not be an ICU per se patient, but it was a very resource, intense patient. Because we have a residency, the initial workup of the patients coming in the resuscitation bays, we had to consider this. Now, Scott Weingart has a very similar program to us up in New York, and his is a little bit different, where the ICU team takes care of the resuscitation as well. We do it a little different. We're more of a consultant service. So the primary ED team, for the sake of training and also so the sake of the attendings, they're not in the chronic abdominal pain ward all the time. When the resuscitations come in, they resuscitate the patient. They do what they normally would do. And they do this for roughly around 90 minutes to 2 hours. That's typically what would happen in the real world. An ED doc should have an idea, be able to get the patient stabilized within a couple hours, call the ICU consultant to help them out, and then hopefully if there's beds available, they should be going up relatively soon. We didn't want to take that away at all. So that's our model. Now we can get involved earlier if they need to, but that's how we set it up. We're a consult service as well as a managing service. We're within the confines of the ED. We're still part on paper, considered an outpatient clinic or an outpatient part of the ED, and all of us are ED docs. Okay, so in order to get a patient over to us though, you have to consult us, put an order in to move the patient over to the geographic location where we take care of them. It is a closed unit, meaning that when we do have an ICU patient we know is going to go to the ICU, I'll call my ICU colleague down with me, we'll round on some patients, they accept them. If they want to do anything for that patient, just give me a call or just give one of my fellows a call. We'll do whatever they need, whatever they want. However, to avoid the confusion or any mistakes, we have one team that's putting all the orders in. The average length of stay for our patients roughly is around 12 hours. It's gotten more this last year just because we've had an increase in boarding time by over 150%. But for the most part, it's around 12 hours. Now, patients that we've identified they're going to go to the ICU, it's about 9 hours. And about 16 hours for those going to the floor. And as you can see there, the majority of that is, the 5 hours after we've decided they've been downgradable, they go to further boarding waiting for a bed. For an educational standpoint, we also for logistics, trying to get the patients moving, getting downstream planning, we get the ICU fellow involved in the care roughly between hour 4 and hour 6. It all depends on the needs upstairs too. We don't want to take them away from a sick patient at the bedside. But a lot of times at night, we'll call the fellow down when they have some time and we'll round on 1 or 2 or 3 patients that potentially could go upstairs. We'll work together on how many beds are available, and we'll make the best effort to pick the most appropriate patient that can go up. A lot of times there's no beds, and we'll just maintain them down there. Nobody's getting freaked out. Nobody's getting bent out of shape. We'll manage the patient. If the fellow has any input of what we can do differently, they give us advice, and we'll carry it out. So that's kind of how we that strategy has really improved relations over the years with the ICU team. This is just a very simplistic flow chart. Showing that patients, they come in, whoops, I killed this. They come in through the ED, they go through the resuscitation bay or the main ED, and then they can get to the EC3. As you can see here, the key point is there's nobody coming directly to the EC3. Now I say that every now and then when we're just getting slammed, we will take patients that are really sick, transfers usually coming in from outside hospitals, will come in directly to us. And then EC3, you can go any of the same places you can before. Moving on to how we worked on the actual structure of this, because we actually needed a space to do this, right? So when we first came about this, before everything at U of M was very heavy architecturally team driven, to where form necessarily didn't meet function, and a lot of times we had to modify how we did things based on the final product that the design team came up with. We did that just completely different, to where now the architects rounded with us, saw what we did, and actually were creating form based on our function, so we didn't really have to alter what we thought we needed to do from an ICU team standpoint. And by doing that, you were able to do workflows around physical barriers like support columns and things like that. This whole approach really was the first time that was applied at U of M, and it was a really big success. We were fortunate is that this is our plan or layout of all ED. We had we've expanded over the years. We're over about 100 beds now. The very top here is where the old pediatric ED was. It's right next to the resuscitation bays. We moved our whole pediatric hospital right down the road, and the ED went with it. So we had the space right next to our resuscitation bays. Again, back to that this is part of the 2-year planning meetings that we had with the architects about this. And after years and years of planning with this, we thought we came up with the best ICU design. It looked a lot like an OR2 where we had, physical space, like in a nice hallway between the ICU and the resuscitation bays. Each trauma bay or resuscitation had a back door to get patients out, etc. We thought this was great. So we did a mock-up. We had a large room that we built a large mock-up to where we actually built 4 of these rooms. We had teams come through and give ideas, put suggestions on the walls. We filled them up with beds, and chairs and other things of what the patients would actually see. We had really good feedback. Again, the feedback came from all walks of life. From the clerks to the housekeepers to our nurses to the attendings. All right, so we found out from doing that mock-up it was a really good idea. Everybody felt that they had skin in the game with that. A lot of buy-in. The significant design change. So we found out, again, the hospital's going to spend a lot of money on this. We found out that with the rooms, they look good on paper, but when you change out what a regular ED bed was for an ICU beds are bigger. And so when we put ICU beds in the room, and then you filled it up with all the good stuff, like the computer and the bedside cards and chairs for family, we found out that, and on the headrest where you had your suction and your oxygen canisters, that if somebody crashed, and we had to intubate somebody, right? You got to pull the bed out to get behind the head of the bed to manage the airway. You found out that the bed almost touched the front door, the wall. So in order to really get behind them and run the code, you'd have to open the doors, and we'd have to be running the code, intubating patients in the hallway. Well, you can imagine designing something to where, in our design, we're coding patients in the hallway by a design that didn't go over too well, and we thought, oh, we can't do this. So the architects were a little miffed that we had to go back to the drawing board, but we actually did that. It put us behind a couple of months, but at the end of the day, we completely redesigned our process, and this is what it looks like now. So we lost that hallway. By losing that hallway, we're really able to really increase our square footage. We're able to make these resuscitation bays very big. Able to increase the size of our rooms now. Each room is about almost 190 square feet, whereas our rooms over 91, 92, over 230 square feet, which from an ED standpoint is really big. It's right about average from an ICU standpoint, but at least now we're from a standpoint of a space size, we're right about where we should be. So then in 2014, we just started knocking down walls, and we really tore this. This was a pediatric ED. We tore this down to the studs, and we were able to open the doors 1 year later. And this is what it looks like now. Came in, before, we had, just one room that had 2 curtains and divided this up. It was cold. It was right outside our trauma doors. And you can imagine in Michigan, the winters can get a little chilly, and those doors opening all the time with the traumas, that this room definitely would get cold. There's no crowd control. There's a lot of voyeurism going around, families looking around the curtain, seeing what's going on next door. Now we have this to where, we have individualized rooms that have, there's 5 of them. They have large trauma, they have large glass doors at the ICU that you're very familiar with, that break away, that we can have climate control. Our old resuscitation bay was cluttered, it's poorly designed. At the end after many years, we'd have this collection, this flea market of all kinds of non-used, resuscitation stuff that just kind of ended up in there. And so now, the way the aspect of this looks, it still kind of looks like a flea market, but at least it's a little bit more organized flea market. Large, bigger space. We put large screen, projection screen TVs on there. Some people think it's for watching the game on Saturday. I don't know, but actually that's that way because it's tied into any visual system. We can put vital signs on there. We can put a lot of other things on there, ultrasound, a glide scope, etc. We have direct access back to our ICU. We also have cameras at the head of the bed and the foot of the bed, so we tape all over resuscitations. Just another example of this. That same space, now we have doors between the rooms, so if we needed to open them and crash, for take care on a large scale mass casualty, we're able to do that for surge control. Then we have dedicated nurses stations for charting and order entry for the docs in the room. That way we're not fighting over the same computer, and we can get this done, because everything's all about documentation, right? So we had that. In our old resuscitation, actually, in our new one now, we also have built an ECMO program, and so we're actually putting patients on ECMO in the ED, and we have enough room to where we have our ECMO circuit in the back of the room there. This is what the actual ICU looks like, the EC3, the Emergency Critical Care Center, looks like. We have a nice open line of sight. The rooms before, that was actually on the left, was our largest room. Now it's a lot less cluttered. We actually have, we take advantage that we have natural light going in the room to help those patients that we stay overnight. Hopefully that can address delirium. And this is one of the reasons we're talking about why we put those monitors in there. Before, you can imagine the attending there looking at the resident, trying to intubate somebody, had to hover around that. Now that we have these multiple video displays, we can actually plug right into it, and we can put that display right at the foot of the bed, and we can see that, when we're at the foot of the bed, and we can do that for our intubations, for our bronchoscopies, for anything that we want to do. The same way with ultrasound. So you can imagine a trauma comes in. Now we can just stay at the foot of the bed while the resident's ultrasounding the belly, and we can look at it, and rather than hovering around the ultrasound machine at the bedside. And you saw this before too. So going on to now our results. All right, it's kind of the good stuff. We opened the doors. I kind of told you, the background of the education mission, the research mission, and the ultimate the patient care mission, and also how it fit in with the health system wanting to expand and manage these critically ill patients. So we opened our doors in February of 16, fully operational April 1st, was kind of a phased in approach. We stopped so each day we went forward. We also went one day backwards from that time, so we'd have a comparable group to compare with. That time frame, going back with our own medical records, stopped roughly around mid-September. That's why you see this weird 958 day. You think, who would come up with a sample size of 958 days? Well, that's just the days going forward and the days going back. So as of September of last year, we saw almost 7,000 patients, a little over 6,500 patients. Remember now, keep this in mind. Keep doing this, huh? Bear with me. There we go. So keep this in mind. We saw an increase in our volume in the ED. So while we were building this, patients didn't stop coming to the ED. They kept coming. All right, so we saw almost a 5% increase in growth annually from fiscal year 14 to fiscal year 17. So just keep that in the back of your mind as we go forward with this. We also saw an increase in boarding hours with these patients. We also saw an increase in admissions. So during this time frame, the patients were waiting longer to go upstairs because we just didn't have any beds upstairs. We were admitting the same number of patients, if not more, so the acuity of these patients was the same, if not going up higher. And we're really under a large constraint of having no beds upstairs. So we averaged about 7 patients over an EC3 a day. Okay, as of today, we have over 8,000 patients through there. 28% of our patients that would have been admitted to an ICU have now been downgraded and go to 4. When we look at our overall before and after amount of patients that we've admitted to an ICU, in the setting of this increasing demand, we've decreased our ICU admissions by 16%. So what that boils down to is almost 2 patients a day are being kept out of an ICU. That's around 1,700 patients kept out of the ICU since we opened our doors. That relates to about 150 ICU bed days, considering these patients stay around almost 2 days in the ICU, saved a month, or around 1,700 ICU bed days saved a year. Now, where do they go? Again, 60% of these patients go to a non-ICU, okay? 30% of them go to the floor, or actually go to the ICU, and then we have a population in here that's of 9% are discharged. Now remember, these were critically ill patients, or really close to being critically ill, kind of on that borderline high resource. 9% of them go to the floor. This is anything from DKA, or actually 9% of them go home. This is a combination of DKA. We're actually sending patients home that had a pH of 6.8 one day, and then now everything got closed and they're doing great. Rather than going to an observation, they go home. Okay, so that's one subgroup that's really benefited from this. Another one would be like overdoses. Before they came in, opiate overdose, it'd be intubated before, an ET tube's a disposition, right? So a lot of times the patients were intubated, they'd go up to the ICU. Well, no, we're taking care of those patients now. We're extubating them, and we're making sure that they have the downstream and support group necessary, and if possible, we'll send those patients home as well. So it runs the gamut of patients that we're able to, what we're able to do down there when you have the time and the resources. We also have another around a 2% expire. Now what this is, we've also been able to really ramp up our palliative care program. We have a large population of patients with cancer and end-stage organ disease such as heart failure and pulmonary hypertension or interstitial lung disease, to where they've had the talks with their primary care doc and they've talked about hospice and palliative care. However, they just haven't quite pulled the trigger yet. Well, we're able to readdress those issues as well, and if they decide that they want to go home, even though they would go to an ICU, we're able to arrange that, or they're able to expire in the emergency department in a peaceful and a respectful way. So overall, during this time frame, again, we're able to decrease our ICU admission rate by almost 17%. Now this is our gross. If you look at before, remember we're averaging around 1,600 patients a year admitted to the ICU, and as of 16 we're down to 1,300. All right, so this is around a 17% reduction. However, if you look at the percentage reduced per admission, not just visit, but per admission, this is a bigger effect. This is almost a 25% reduction. The units that are affected the most, primarily far and above, is the medical ICU. We do have capacity in our surgical ICUs, but our medical ICU and our cardiac ICU, non-surgical, were the two that are affected the most with this. How are we able to do this? What patient population were able to do this? Well, by far and above, it was the short stay patients. It was the patients who go to the ICU who would have normally had a discharge order to go to the floor within 24 hours. That's the biggest impact that we've been able to make in this. We've decreased those admissions by almost 40%. Patients who normally would have gone to an ICU and then we watch them overnight, for a GI bleed or whatnot, and they have orders to go out to the floor the next day. We're able to take care of those patients very well in the emergency department. This is one example of the pathways that we currently have. At the time, BiPAP, intubation ventilator orders was the highest one, followed by sepsis. But the nice thing is that we have new pathways that are now going to come online. We have up to 15 pathways, the evidence-based pathways that our patients are following down in the emergency department. You might be curious as to what happens with all that capacity upstairs. Well, during the time frame that we're talking about here, we've been able to increase outside transfers from ICU to ICU now by 30%. All right, so an example before is what our medical director was talking about. Every year there's about 2 or 3 patients with pulmonary hepatic failure get referred to us for a transplant, to come in to manage their liver disease and get listed for a transplant. If we're not able to, we have to turn about 3 of these down a year. Now these are patients that we're able to get into our ICUs and get the appropriate care that they need. Now, a question that comes up is the safety about this. Are we just pushing the safety to the floor, and there's more people that are now coding on the floors after we manage them in our EC3? And what are we doing with mortality? So if you look at our patients who were transferred to the floor and then had to bounce to the ICU within 24 hours, there's no significant increase at all between the before and after period within this population. So this is looking like this is a safe, and this has been proven out year after year. This has been a safe model and a safe paradigm. Same way with looking at mortality. We're not seeing an increased mortality with these patients who are going through EC3 as well. Cost effective, the big bugaboo, right? What's this? You can do anything if you throw enough money at it, right? Well, we in the hospital, it's very hard to really understand what the cost is. So we did our best to just kind of do a crude analysis, and granted, this is crude. We looked at the pre-ICU number 1. That swim lane number 1 is essentially before you went to the emergency department, then you went into the ICU. Now that we have EC3, there's 2 pathways. You go to the emergency department, you go to EC3, and you either go to an ICU or you go EC3 and you go to the floor. All right, we looked at all the different parts of cost. This is what costs us, from his radiology, pharmacy, nursing, lab tests, ancillary support, etc. We built in the length of stay, okay? So if you make it to an ICU, you're gonna stay a little bit longer, about an average of a day more coming through EC3. However, we're able to decrease your amount of ICU admission. So we baked that into the formula as well. And at the end of the day, you can see that the pre-EC3 is the purple line right there. That's where these patients would just go from the ED to the ICU. The first day costs are roughly the same, but if we're able to avoid the ICU, which again we're able to do in about 16%, now you drop down to the green line. Okay, these sick patients, the same propensity scoring, now are able to avoid the ICU. They avoid an extra day or 2 days in the ICU, and they actually go home a day early, from going to the floor. That cost, that's a cost saving, in that line right there. However, if they do go to the ICU, we're actually able to save around $1,000 or so a day from the care they're able to see front load. And if you look at this based on day, we're able to save, the first day patients going through EC3 is not that much of a savings. However, we're talking about the second day, third day, fourth day out, we're looking at about $2,000 to $3,000 a day we're able to save from these patients based on that cost formula we mentioned before. So not to bore you with how we thought about this, is basically algebra. If you look at absolute difference of 232 patients, that was a gross number of patients not going to the ICU, you save anywhere from around $2 million a year to almost $6 million a year by doing this model. And the key is just avoiding the ICU. Now, again, limitations at single center, before and after. Not all ICU admissions go through the EC3. We can do better at what we're doing, in our final cost analysis and process. I'm not the one that came up with this. Actually, Aki Grunbeck. Anybody know who Aki Grunbeck is? He was the first critical care fellow in the United States. He was at Pittsburgh, and he ended up being the program director and the chairman at Pitt, and he was one of the grandfathers of critical care. He actually, in the textbook of critical care, he wrote the preface. Many critically ill, patients no longer need admission to the hospital if diagnostic workup and treatment can be completed in an ED short-term ICU. I'd like to say, since he was one of my mentors, that I actually read that and I based this on that. I actually just stumbled across it looking for a quote to put in a slide deck. So, yeah, Aki was very he was a prophet of so. So I can't take you to University of Michigan, but I can actually bring a little bit of it there and hopefully, kind of show you what we go through.
The Emergency Critical Care Center, or the EC3, was designed to provide our critical care patients with continuous and seamless high-quality critical care right from the beginning. We were intentional about incorporating a lean-based design process into the design really from the earliest stages.
Our EMS entrance flows right into our resuscitation bays. Each resuscitation bay is equipped with a power boom and large monitors designed for 360-degree care around the patient. The monitors allow for the entire room of providers to see information on the patient at once. Each bay is also equipped with cameras to record patient care for quality assurance and team education. We provide dedicated teaching space within the resuscitation bays by installing digital whiteboards, which double as patient care monitors and allow for real-time education. Right outside of the resuscitation bays, a shelving unit was designed to hold infrequently used life-saving equipment that staff needs to have immediate access to in an emergency situation. Sliding glass doors offer staff the option of closing off space for crowd control, noise, temperature control, and isolation. Should a massive casualty incident take place, the doors can all be opened to allow one large patient care bay. From our resuscitation bays, there is a seamless transition into our emergency critical care center, offering our staff the ability to provide longitudinal critical care to our patients, continuing from the resuscitation bays into the EC3 and upstairs into the OR or general hospital. Each room was designed with the head of the bed clear from equipment to be sure nothing gets in the way of patient care.
To improve patient safety, we tried to centralize a nursing station, provider station, where we could all communicate together and also see across the entire area. A lab was centralized within the unit with double-sided access from the resuscitation bays and the EC3 rooms to allow for sample drop-off from both sides of the unit. Each room includes an electric bariatric lift to facilitate patient movement instead of causing physical harm to staff trying to move the patient on their own. Patient rooms were designed with natural light instead of the usual fluorescent lighting to help with healing. Artwork adds comfort for patients instead of stark white walls. We sacrificed designing more rooms to design bigger rooms with more space for everyone. The new rooms are larger than code requirements and provide space on one side for the caregiver and plenty of space on the other side for the patient's family or visitors. And most importantly, our new rooms provide comfort and privacy for our patients and their family members.
Our new Emergency Critical Care Center has been a labor of love from so many disciplines across the entire health system. We are very proud to have a unit that can provide the highest level of care and healing for our critically ill and injured patients. All right, so to wrap it up, the emergency-based ICU really is a safe and effective approach, towards treating these critically ill patients in a that would be waiting for a traditional ICU, especially in the less than 24-hour period. It takes a large multidisciplinary team to do this. We really can't do this alone. We got to break down those silos. We got to work together, from all aspects of all ICU standpoint. And using a lean-based format, we're really able to do this right. And I have to say, we're really fortunate that we didn't make a lot of mistakes and have to go back and do retrofittings to the approach to this. So using some type of a lean-based format with this is essential. And then continued data-driven outcomes is essential to going forward with this. So if you're going to do something like this, we really need the data to kind of tell you where you're going to move, in what direction, and how to modify that. So with that, remember I put up a couple questions, and they should be pretty straightforward. You're not talking about C4 levels or complement here. So after 4 hours, mortality increases the longer an ICU patient is kept in the emergency department awaiting an ICU bed. True or false? Not if they're in an EC3 area, though. Right? Not a trick question. This is not about Michigan. This is about overall. All right, exactly, true. So what big problem that facing all of us are patients waiting in an ED for an ICU bed. Mortality really starts to go up. It looks like around 4 hours or so. And then the last one is an ED-based ICU increases the yearly ICU admission rate because that's what we do. So do we increase ICU admissions because we're a hammer and everything's a nail and everybody has to go to inpatient ICU? True or false? False. All right, good. False. Excellent. So this is just a very small smattering of the team that we had together. And again, I'd like to thank you for your attention and your time, for letting me tell you the journey that we just went on. Thank you very much.